Thank you very much. On behalf of Professor Dimitris Linos, who is the president of the society, of our Endocrine Surgical Society. Unfortunately, he has a delay on his way back home from the United States, and he's expected later on this evening in Athens. Professor Martin Waltz, thank you very much for participating in our meeting. We all know that you have one of the largest series in the world regarding minimally invasive surgery for adrenal tumors. And you have the largest series in the world regarding retroperitoneal endoscopic adrenalectomy. So I think we all know that you are the pioneer of the technique. So we are expecting your lecture with topic surgery for pheochromocytoma.
Unmute. Okay.
Can you hear me now?
Yes, of course.
Okay, good. Good afternoon to Athens from Germany. And I would like to start my presentation immediately because there is some delay, I think. And thank you for the nice words in the beginning. My topic is the pheochromocytoma, just the pheochromocytoma, not all the other tumors of the adrenal gland. And I understand that I should talk a little bit about my private ideas about the pheochromocytoma surgery. Well, the place where I'm coming from is that hospital in the city of Essen. Essen is about 600,000 people living here. And it's a few years ago that Dimitris Linos was one of my guests, and we joined some surgeries and we did 6 adrenalectomies in one day. So this is a few years ago. We are a little bit older now, but just a little bit. Well, just to give you some private story about the pheochromocytoma, and it's really a very special tumor for me, because in 1977, when I was a young student, I did the anatomy course, macroscopic anatomy, you can read here. I had to pass that course, as every medical surgeon, student has to pass. My cadaver had a pheochromocytoma. And you can imagine that this is extremely rare. And if you calculate a little bit how often you have a cadaver that you will see as a medical student, how often pheochromocytomas are there, it might be that once in 1,000 years, a later surgeon for pheochromocytomas will have this situation. Well, and of course, the first case I did, the first case on pheochromocyte surgery I did was in 1992, as you can see here. This was a young lady. She was pregnant. She had MEN2A. She had 2 tumors, one on the right side and one on the left side. And I did my first case on the right side with a total adrenalectomy and a partial adrenalectomy on the left side. Of course, open surgery. And I remember very well when I touched the uterus during the surgery, and it was a very strange thing, I said. And of course, there were no events postoperatively. The patients and child went well. And we met together 26 years later. This is the patient and this is the son. And she had never had any corticoid substitution after that surgery. So she's very well after decades of years. This is my first surgery. I did pheochromocytoma surgery. Well, afterwards, we did a lot of publications about the pheochromocytoma, and for my top 11 ranked papers, 8 are about pheochromocytomas. 1 is about thyroid, 2 are about esophagus, and the others are about pheochromocytoma, more or less. Well, let's talk about a little bit of surgical technique and about perioperative treatment. These are my main topics today. And of course, if you have the diagnosis of pheochromocytoma, this was the last case in this week in Essen. there is automatically the indication for surgery, no doubt about that. And if you have like this, a unilateral pheochromocytoma, or you have a para-aortic thoracic paraganglioma, or you have a little para-iliac paraganglioma, or you have bilateral pheochromocytomas like in this case, or you have a paraganglioma like this. This is not a pheochromocytoma because it's touching the vessels here, so it must be a paraganglioma. Or finally, a very huge paraganglioma inter or autocaval in the retroperitoneal. All these chromaffin tumors mean surgery if they are found, and the indication is automatically. This is my experience about the chromaffin tumors. You can see that we have now about 750 tumors in this field. We have more than 2,600 cases of retroperitoneoscopic adrenalectomy, 600 and so by the pheochromocytoma group. And my first message is, since I started pheochromocytoma surgery in 1994, we did all of them 100% minimal invasive. Not any open and not any conversion in these cases. And in the paraganglioma, it's a little bit different because we had 2 open that could not be removed by minimal invasive technique, and we have 2 others that we had to convert. So, pheochromocytoma surgery means also for the paragangliomas, in most of the cases, almost always means minimal invasive surgery. If you have a patient with a pheochromocytoma and you plan open surgery, it's not fair for the patient if you know anybody who is doing that minimal invasive, I would say today. Well, so my surgical approaches to the pheos and to the paragangliomas, and let's first look at the pheochromocytomas. And I included all the cases, including those cases I had this week. We had this week 3 pheochromocytoma cases. And you can see that most of them are done by the retroperitoneoscopic approach and sometimes a laparoscopic technique because they had combined tumors maybe with the paragangliomas or other pathologies. So this is exceptional that we go by laparoscopy. Usually it's from the back. And if you see these bilateral pheochromocytomas like in this MRI, and the question is how to take them out. When you put the patient in one position, lateral, you know, you have the spleen, the pancreas, the stomach, just in front of you. When you put it to the other side, you have the liver in front of the tumor. And if you go from the back, it's a very direct approach. Here is the skin, here is the tumor. On the other side, it's the same. So it's a very simple and quick access. The best is from the back. Well, I would like to share with you a film, and this is a tumor. This looks like a pheochromocytoma. It's not, to be sure or to be fair, but now you see the patient in the position. The position is in the, put the sound a little bit down, in the flat position. The spine has to be horizontal. And the key is to open the retroperitoneal space just underneath the 12 rib. It's important that you feel the 12 rib and the tip of the 12 rib with your finger. You introduce your finger. You see the video is not edited at that beginning. You introduce your finger and put another port on the finger guidance into the retroperitoneal space. There is no colon, there is no other organ, there is nothing except the retroperitoneal fatty tissue, and it's absolutely safe. You never hurt any other organ by that. And then you bring in this inflatable balloon, trocar, that allows us to cover this incision that is a little bit wider than 10 millimeters, and we start with a retroperitoneoscopic approach with a gas pressure of 20 millimeters of mercury. So when we now introduce the camera into this port and the grasper on the other side, we find the grasper inside the retroperitoneal space. And the first layer that we see is Geroda's fascia, and this has to be opened first. So by pushing down Geroda's fascia, opening Geroda's fascia, we create the space in the retroperitoneum, and in this case, it's an 8 centimeter tumor, just to
recording in progress.
And it's an 8 centimeter tumor, and so it could be a very big pheochromocytoma. There is the tumor, the liver is on the other side, the spine is on the other side, and of course the kidney is somewhere down, and we will see it immediately. The right kidney is just in front of us. So what we do now is we introduce a third port. This third port will be the port for the camera. And it's very important that it's an eccentric situation, so the camera port is not in the middle.
Recording
it's eccentric,
stopped.
meaning it's near the spine. And the first step is now to dissect the upper pole of the kidney first. Upper pole of the kidney first, and by this, mobilizing the lower pole of the adrenal or the adrenal tumor automatically. So the principles, just to prone position, CO2 pressure of 20, 3 ports, en bloc resection of the adrenal with the surrounding fatty tissue. Don't isolate the tumor. Upper pole of the kidney first, that's what we just did. Lower pole of the adrenal second. Main vein without clips, and fragmentate the tumor if necessary. So in this case now we have the renal artery, and there are 2 arteries in this special case, and dissect them free, and by this automatically we cut all the arteries from these arteries, from the renal arteries and to the adrenal tumor. And by this we automatically see in the back the IVC, inferior vena cava, and the renal vein is also there. So now we free the IVC from the back. So the kidney is down, the adrenal tumor, very huge one in this case, is up, and we dissect now from inferior to granulate. And as you can see, the IVC, the vena cava, is a very, very safe structure. It's not easy to make a hole into this vein. It's a big vein. And by the magnification of the minimal invasive surgery, you can always have a perfect control over this big vessel. Well, some results about the PHEOs. 622 operated in this technique. Mean operating time is around 45 minutes. Blood loss is less than 20 milliliters. Conversions 0, as I mentioned before. Mortality 0. So very, very safe procedure. As you can see now, we go a little bit around and come to the, on the left side. On the left side, you see, is the liver. On the right side here of the patient is the spine. Of the screen is the spine. Patient is in the prone position, so we step by step mobilize this tumor gently from the peritoneum. This is the peritoneum behind the right lobe of the liver. And by this we automatically will reach the adrenal vein. And the adrenal vein on the right side, as you all know, is the difficult step. This is the right adrenal vein. And as I just said, now comes the clue. And it's not, oh, sorry. Oh, shit. Sorry for that little pressing here. little mistake by my side. So sorry for this insert there. It comes in a second. Now you can see this is the right adrenal vein. It's less than 1 centimeter in length. The ligature goes around and it's not edited, as you can see. This moment is not edited. The ligature goes around and takes it down. And as I said, never put clips there. If you put clips there, you can remove clips and it will bleed afterwards. If you're not putting clips, and we have more than 1,000 cases on this vein, it will never bleed. Ligature is very, very safe, or on any other modern instrument. So this usually is the final step of dissection, and then it will be put into a bag. And what it means for the patients, if they are operated in that style, this is on day of surgery. This patient is running down with me in the ward. It's few hours after the surgery, because we are doing extraperitoneal surgery. It is like that. Finally, the tumor will be removed. We morcellate the tumor, and then the surgery is finished. Let's go to the paragangliomas. We have 124 paragangliomas, and most of them, again, are done by the retroperitoneoscopic approach, some by the laparoscopic approach. And just to show you a laparoscopic case. This is an old lady, 77 years old, attacked since 5 years. You see the CT scan here. You see the PET scan there. So it's a tumor just on the aortic bifurcation. People call that Zuckerkandl's organ paraganglioma. And it's laparoscopy. That means the first step is to mobilize the ileocolic junction and to put the patient into the anti-Trendelenburg position, that the colon and the mesentery falls up into the upper abdomen. And by this, you will automatically free the iliac arteries and the ureter you just saw. And now the paraganglioma is already there, as you can see. This is the iliac artery, the right iliac artery. And now the dissection is only very editing again. This is the tumor, about 2.5 centimeters in size. These tumors are always very, very good vascularized, and therefore it's necessary to do a precise dissection around the tumor. You see there's a little vein. These veins enter into the iliac veins. The arteries come from the aorta or from the iliac arteries, but if you go step by step, it will not bleed. So there is no reason to do open surgery in a case like this. It's very, very simple, very, very easy for laparoscopic surgeon to remove these little tumors. And of course, it's just with one 10-millimeter port and two 5-millimeter ports. So this is now the end of the dissection of this little tumor. The paragangliomas become dark red-gray when they are mobilized completely. You see the iliac arteries, the iliac vein, just at the bifurcation, but absolutely safe and easy surgery. Put it into the bag and remove it. And it's no reason to open up the patient for tumors like this. All the para-aortic, all the interaortocaval, all the paracaval paragangliomas can be removed like this. And often it's very easy. This is a 35-minute surgery. There's another case, and I mentioned this patient before because it was a boy from South Africa. And he has this huge paraganglioma in the retroperitoneal space. This is the cava and the aorta and somewhere between, and it's on both sides of the retroperitoneum. And what we did a few years ago, a retroperitoneoscopic approach to both sides. This is the adrenal gland. The kidney is down here. The aorta is just beside here. And this is the mobilization of the tumor on the left side, as you can see. And then we went to the right side, and then we started the dissection of the tumor from the IVC. The IVC is the most important thing. And you will understand that the IVC has to be freed from the tumor because the tumor is exactly between the aorta and the big vein. And it was really necessary to take it down step by step. The whole surgery took around 8 hours, and it's endoscopic, as I mentioned, on both sides. So this is the most extreme case we did by the retroperitoneoscopic approach. Now you see the tumor is mobilized more and more on the right side, and because it's already mobilized on the left side, now we can take it into a bag and have the complete dissection of the tumor. Of course, you can see the liver from the back. The segment 1 from the liver is there. Now it's in the back, it's removed. And that's the end of the situation. The kidney is in front. The IVC is just in front of us. We clean the field and we can look from both sides. You see, the other instrument comes from the other side and also from this side. This is from the left, the other thing was from the right. So extreme retroperitoneoscopic minimal invasive surgery. You see Dr. Adesina is on one side, I'm on the other side. And this was the situation. 6 little ports into the back of the patient. Well, the nice thing of this patient is that 6 years later, here this is in Johannesburg. I'm allowed to show these pictures because he's Bayern Munich fan as I am. And so he sent me these pictures and he's fine. Today he's a student. His cardiomyopathy he had has disappeared. So he's healthy, everything is perfect and no local recurrence, though SDHB mutation. Well, so my recommendation is if you have a paraganglioma above the vessels of the kidneys, do it retroperitoneoscopic, and in the lower ones, do it laparoscopic. It's easier. And we published that also for the pediatric cases. So this is how we are doing the paragangliomas. Well, now let's go to perioperative treatment. And let's say that's the topic concerning alpha receptor blockade. The story of alpha receptor blockade in pheochromocytomas is like a dogma. It's like a fairy tale. And it's something like fake news. And I just want to show you why. It's time to change a more than 50-year-old belief that you cannot go to surgery for pheochromocytoma patient without having blocked him before. Well, most doctors, endocrinologists, anesthesiologists, also the surgeons think that if you have a patient with a pheochromocytoma and you block that patient, the curve of the intraoperative pressure will be something like that. And you also think that if you are not doing the pre-medication, the intraoperative pressure will be something like this, swinging up and down all the time. You also may think, and this is, I think, in the brain of all these doctors who are caring with the pheochromocytomas, is that this is a safe situation if the pressure is not swinging up and down. And most of you may think that it's dangerous if the pressure is going up and down during the surgery. Well, and finally, everybody thinks if you have a swinging pressure intraoperatively, you can change that to this type of pressure pattern by pre-medication. So if you block the patient, it will be like this. This is the idea in most of the brains of the doctors. And unfortunately, it's not the truth. Well, let's go to the classic paper. And this is the classic paper. After that, the world changed to alpha blockade. This paper is from 1967. And this paper describes 17 patients with blocking with alpha blockade in pheochromocytomas. And of course, it is said in this paper that if you do blocking prior surgery, you will have preoperative vasodilatation and plasma volume will expand. And it says you can control the blood pressure by this medication. And there will be no swings of blood pressure up and down if you block the patients. And finally, there will be no abrupt falling of the blood pressure after the tumor removal. All these things we learned as medical students or as young doctors always, and it's in the textbooks and it's always in the guidelines. So it must be the truth. Unfortunately, not. When we go into this first paper, this decided for everything in the next 50 years, we see case number 4. Case number 4 is not blocked, is blocked. The first thing is you see that the operating time was more than 4.5 hours for the pheochromocytoma surgery. Second, you can see that the blood pressure on the blocking went up to probably 300 in this case. After removal of the tumor, the pressure went down. Blocked patient. Let's go to the next one. It's the original paper. Case number 5, blocked. Look again, operating time is more than 4.5 hours. And of course, the blood pressure went up and swung up and down for more than an hour, I would say, to 250 and so on. So there was no clear and stable blood pressure situation, even not in the very first paper that has always been cited as the reason why we are blocking. Well, so when we look at these arguments for alpha blockade, the only thing that you can say today is it's not true. It was never true, even not in the first paper, and therefore we have to forget about that. Well, when we compare 1967 to 2021, what has changed? Of course, the diagnosis of pheochromocytomas is based on blood tests, on MRI, on all the other things we have today. It was not existing in 67. It was difficult to measure catecholamines at that time. The anesthesia has changed completely. Everything is different than at that time. All the observation, all the medications, all the drugs, everything has changed. The surgery has changed completely to minimal invasive surgery, but the pre-treatment has not really changed. Most of you will use alpha blockade still and insist on that. And the reason is because it's a tradition. And our history in Essen, we changed that. We changed that around 10 years ago. And we changed that like this, that until 2009, we blocked almost all patients. And after that, nearly no patient. Very few patients are blocked since that time, independent of their pattern of catecholamine secretion. Well, we did papers on that, and this was the first paper published in the British Journal of Anesthesia. We had 121 patients with alpha blockade, 182 without alpha blockade, all operated minimal invasively. And you see the systolic maximum pressure intraoperatively there was no difference. Alpha blockade does not help. And but alpha blockade means that you have more hypotension during the surgery, and they may need more norepinephrine infusions if you block the patient. So they are less stable than the others. So the summary of this paper was no major complications with or without blockade and more arterial hypotension after blockade. And just to show you how patients are doing, this is a patient of a pheochromocytoma surgery the day before, and he is, again, this is also my test, always my test, is running down the ward. All these two patients had also pheochromocytoma surgery the day before, no blocking, just 2 liters of infusion intraoperatively, no intensive care unit, nothing. It's like that, and they are really happy. It's not a fake, it's literally like this. Or this boy had a thoracic paraganglioma 2 days ago, and we published that case also with a paper in the New England Journal of Medicine. There is nothing, never blocked, nothing before. Well, we did another study, and this study is an international study, including the hospitals from the United States, from Japan, from Australia, and from Europe. And now we have 1,860 procedures, most of them operated by minimal invasive surgery, and we published this in the British Journal of Surgery in 2020. And we found out the mortality is low in pheochromocytomas today. The cardiovascular complications occur in around 5% in this study. And what we found is that the mortality for blocked or non-blocked patients is the same, but the morbidity is 10 times higher if you block the patient. It's due to hypotension. Well, so alpha receptor blockade means pseudo-safety. Nothing is different when you block the patient. You harm the patients because of the hypotension, and therefore alpha blockade should be stopped. It should be stopped immediately. Well, so now I come to summarize. The therapy of the pheochromocytoma today is minimal invasive surgery without pre-treatment. Thank you very much for your attention.
Thank you very much, Professor Waltz, for this excellent presentation, indicating your huge experience in this field of surgery, in adrenal surgery, and very impressive videos regarding the paraganglioma with very nice techniques. Also, this proposal to abandon the blockade, the preoperative A blockade for the pheochromocytoma surgery is very interesting. I think it has been proposed by other centers, mainly in France. In the States, they are more hesitant for this change. Here in Greece, most of us, we still use A blockade, but I think that we must all consider to alter the preoperative pharmacologic A blockade. So this manipulation may be abandoned in Greece as well. I think that we need some work with the endocrinologists and the anesthesiologists. And,
sure.
I would like, yeah, sure, with both. And
both, yes.
If possible, Dr. Kafetsis, who is one of the pioneers in adrenal surgery in Greece, to comment on all of these things, interesting things.
Well, thank you. Thank you very much for your excellent presentation, Professor Waltz. And thank you, George, for your kind introduce me. I think I have no experience for the retroperitoneal approach, but it seems to me very easy, easiest than the laparoscopic. But I don't know the space exactly. That's why I have a hesitation for this procedure. But when I discussed that with Professor Linos, that was a friend of mine, it tried to convince me to try the retroperitoneal approach. If I have some more pheochromocytomas, I'll try to do it for this kind of approach. And I'm very impressed from your announce about the alpha blockade, and it's very, very difficult to convince the anesthesiologist because for many years, as you said, they use this kind of blockade. Thank you very much indeed for your presentation. Thank you.
I don't know if Professor Kostopanagiotis is here with us this evening. Then if Dr. Kyriazopoulou, consultant endocrinologist in Nigeria Hospital, could comment on very interesting proposal.
Yes. Thank you very much, Professor, for this excellent procedure. And I have to say that my first patient with pheochromocytoma was a pregnant woman after birth. She had hypertension during pregnancy, and nobody had the opinion to have any evaluation for her. And this I have to say that every mass in adrenal, we have to do to exclude pheochromocytoma before any surgery. We agree don't have a treatment with alpha blockers, but anesthesiologists want this medication, and I believe that surgeons may have a proposal to them to stop this medication. And thank you very much.
Thank you very much. May I add some comments? Of course, we did this change with the anesthesiologist. So the first author of these papers I mentioned is my anesthesiologist. And he is absolutely convinced about this, that we are on the right side, let's say like this. You know, I have a little bit the impression in this alpha blockade story that people think as more as you repeat something, it becomes more and more truth, yes. You know? And we all had some political, let's say, experiences in the last 5 years from over the ocean, and things that are always repeated become more and more truth. And the alpha blockade story is something like that, because nobody really asks, is that really the background? And if you go to the basic data, you find out it's a story. And therefore we should work against it, because we harm the patient. If you go for alpha blockade for 2 weeks or so, you have to hospitalize the patients. You have to go take them into the hospital and let them, you know, lay down and things like this. And they are not doing well in this period. And it's absolutely nonsense. It's not necessary to do it anymore. Because if you put them to the OR, of course, the anesthesiologist has to be aware of modern drugs to control the pressure, to inflate the volume. And you know, this argument that by alpha blockade, you increase the blood pressure. No, you increase the blood volume. It's stupid, because everybody of us knows if you have a line here and you put 2 liters of volume in there, it takes 10 minutes. Why to take 14 days or even longer to increase the volume by alpha blockade? So the modern surgery and the modern anesthesiology should be able to make safe situations for their patients.
Thank you very much.
Thank you very much. Is Dr. Tsakarakis with us this evening?
Yes, I'm here, yes.
Stelios, good evening. Dr. Tsakarakis, he's consultant endocrinologist, senior consultant endocrinologist at the Evangelismos Hospital. He's one of the Greek contribution at the European Society of Endocrinologists, and one of the 6 or 10 persons who organized the recent guidelines in endocrine surgery for the whole Europe. So we need your comment on this proposal that we had this evening from Professor Waltz, and we are all aware of the topic, and we need your opinion.
I think this is quite challenging. I will be very confident to do that if I was working in Essen with Professor Waltz. But unfortunately, in Greece, no one of my patients will be operated with no preoperative preparation with alpha blockade. I can see that there is much concept on what Professor Valls said. And of course, there are so many things that have changed recently, like the time of surgery, like the anesthesiology, and all the supportive measures that we are offering to these patients. But unfortunately, we have to stick to our protocols. And if we want to convince the anesthesiologists and the whole team, I'm afraid that it will take some time to operate with no alpha blockade.
Okay, thank you very much. Thank you very much, Professor Waltz, for this fantastic lecture. And we can move again with Dr. Tsagarakis, who is going to talk us about Cushing, subclinical Cushing syndrome. Dr. Tsagarakis has also done a lot of work on Cushing syndrome, many publications, many trials. So we thank you very much.
Oh, thank you, George, for the kind introduction. And also I would like to thank the organizers for giving me the opportunity to participate in this webinar. I'm afraid my presentation won't be so exciting. I have no videos, and it is not about endocrine surgery, it's just endocrinology. And my topic is subclinical Cushing syndrome. But I have to share my screen first, which is quite important. Can you see my screen?
Yes, of course.
Okay, thank you. So, as subclinical Cushing syndrome is defined, the setting of abnormal endocrine tests compatible with cortisol hypersecretion in patients with adrenal incidentalomas, along with the absence of stigmata of Cushing syndrome. As you all know, adrenal incidentalomas are mass lesions in the adrenal glands discovered by various imaging procedures performed in the absence of evidence for an adrenal disorder. Prevalence varies between 0.5 to 4%. And with an estimated frequency of approximately 10% for subclinical Cushing, you realize that this is a common problem, as it concerns at least 0.5% of the general population, with this proportion being higher in older age groups. What I'm supposed to do today is to try to give you an update on subclinical Cushing. And to this end, I will try to answer what are the diagnostic criteria, what are the implications, what is the effect and indications of surgery, and at the end, I will try to give you some updates on few challenging issues like bilateral adrenal incidentalomas, the so-called Cushing, and the implications of steroidolomics. Since I was privileged and honored to be part of the group that drafted the 2016 European Society of Endocrinology and ENSAT guidelines, most of my statements will be based on information given in this really hallmark paper. Amongst the different terms used over the years, including preclinical Cushing, subclinical, subtle, subclinical autonomous glucocorticoid hypersecretion, etc. The recent guidelines of European Society selected the terms of autonomous cortisol secretion, and some of the members extended that to mild autonomous cortisol excess, as delineating better this situation. During my presentations, I will use all these terms depending on what terminology was used in the studies I'm going to present. So, to start with, in terms of diagnosis, these are the tests assessing the cortisol status and include overnight or low-dose dexamethasone suppression test, midnight cortisol, either serum or salivary, and 24-hour urinary free cortisol, with the ACTH measurement used in order to exclude ACTH dependency. The European Society guidelines strongly recommend the use of 1 milligram overnight dexamethasone test based on simplicity, also based to the fact that it was incorporated in the diagnostic algorithms of most studies, and also because of pathophysiological reasoning. The pathophysiology rationale of this test is illustrated in this cartoon. In the case of mild autonomous cortisol secretion, the HPA axis is only partially blocked. When we give dexamethasone, we fully suppress pituitary ACTH, and thus the cortisol level obtained after dexamethasone administration represents the non-ACTH dependent portion of cortisol secretion, providing thus a quantitative measure of autonomous cortisol secretion. It is now well appreciated that there is a continuum of autonomous cortisol secretion. And based on European Society guidelines, post-dexamethasone levels of less than 1.8 micrograms per deciliter exclude, while levels over 5 micrograms per deciliter confirm autonomous cortisol secretion, with levels in between considered as intermediate. Further tests are implemented only in cases of autonomous cortisol secretion and include measurement of plasma ACTH, 24-hour urinary free cortisol, and if available, late-night salivary cortisol. And it is also recommended to repeat testing in 3 to 12 months in order to increase confidence about the diagnosis. In case of possible autonomous cortisol secretion, further testing with plasma ACTH or repeat dexamethasone suppression is indicated in case of comorbidities. So, what comorbidities are related to autonomous cortisol secretion? So far, data on comorbidities were derived from small-scale heterogeneous studies, lacking comparison to a reference cohort. The Urine Act is a European network created and led by Professor Wibke Art, recruiting patients with newly diagnosed adrenal tumors from 14 centers, including our own center as well. In this setting, a large-scale case control study was performed, including 1,308 prospectively recruited adrenocortical adenoma patients. Based on the 1 milligram dexamethasone suppression test, patients were classified into patients with non-functioning adrenal tumors, patients with mild autonomous cortisol excess, either grade 1 or grade 2, and also few patients with overt classical Cushing syndrome. The cardiometabolic disease burden of these patients was compared to 5,268 patients obtained of the NHS database of England. And cardiometabolic disease burden, including hypertension, type 2 diabetes, and dyslipidemia, in all 4 subgroups was significantly higher than in controls and increased in line with cortisol excess. And therefore, based on these large-scale data, it is now relatively well established that mild autonomous cortisol excess is clinically a high relevant cardiometabolic risk condition, and all patients with adrenocortical adenomas will give careful assessment for hypertension and type 2 diabetes. The risk of osteoporosis has been extensively investigated by Chiodini's group in Milan. In this study, they clearly showed that the presence of subclinical hypercortisolism was related to vertebral fractures with an odds ratio of 7, providing good evidence that subclinical hypercortisolism is associated with increased incidence of fractures, low bone mineral density, and low bone quality. Another important implication was the finding of decreased survival. As shown in this study by John Newell Price group in Sheffield, patients with adrenal incidentalomas and a post-dexamethasone serum cortisol of over 1.8 micrograms per deciliter have an increased mortality, mainly related to cardiovascular disease and infection. Despite death being due to events that are plausibly related to excess cortisol, it is not possible to know whether the patients died because of their hypercortisolism, and this can only be assessed by prospective studies aiming at reducing the effects of that hypercortisolism. So, autonomous cortisol secretion is associated with cardiometabolic risk, osteoporosis, and increased mortality. And the question is, are these implications reversible or not? Like in clinical Cushing's syndrome, surgery is the only means to effectively remove cortisol excess. In this review, 10 years ago, we summarized 6 studies, 5 retrospective and 1 prospective, that compared the surgical outcome between patients undergoing surgery and patients undergoing observation. Obesity, hypertension, diabetes, and dyslipidemia, as you can see in these categories, in the surgical group, there were more I's, that means improvements, while in the observation group, for all these categories, there were more W's that correspond to worsenings. A most recent study analyzed 8 studies. Improvement of comorbidities was found only in surgically treated patients. And so to sum up, although current evidence demonstrates a beneficial effect of surgery, the numbers are still too small, and the definitions of response and also the results are not really consistent. So this lack of robust data on surgical outcome is reflected in the algorithm proposed by the European Society and SAT guidelines, with surgery recommended mainly for patients with autonomous cortisol secretion and comorbidities, while it is not so often, but actually rarely recommended for all other categories. However, this is not a yes or no algorithm, and a major point of the recommendation was that of an individualized approach, suggesting to consider, except potentially related comorbidities, the age of the patient, the degree of cortisol excess, the general health, and of course, patient's preference. Another major question is, are there any medical options? These are 2 24-hour cortisol profiles obtained by this new technique that is currently under investigation in our department as part of the Ultradian project. As you can see, the green profile corresponds to a much greater secretion of cortisol during the daytime, but not during sleeping, when the red profile shows no suppression. The green profile corresponds to a competitive basketball athlete. The red profile corresponds to a patient with classical adrenal Cushing syndrome. So in Cushing syndrome, the major difference is not the total cortisol secreted, but the cortisol secreted inappropriately during the sleeping hours. On the basis of this, John Uriel Price in Sheffield conducted this proof of concept study in only few numbers of 6 patients, targeting night cortisol. And the use of time metarapone, which is an anti-adrenal drug, reset the cortisol rhythm, as you see in these 2 profiles of all the patients. And this unique treatment paradigm was associated with reduction in the cardiovascular risk marker IL-6 and leaves us with some promise for a future medical option. So, to summarize, our recommendations for surgery are the following. We consider surgery only in patients with autonomous cortisol secretion, plus at least 1 significant comorbidity, preferably hypertension or diabetes, plus a clear interest in surgery by the patient. Alternatively, especially for patients in whom we are not completely convinced, we increasingly consider a diagnostic treatment with 6 months of anti-glucocorticoid administration, example, given metarapone or whatever other medication is available. A word of caution in case of surgery. Because of cortisol excess, the pituitary ACTH secretion is suppressed. So after the removal of cortisol secreting adenoma is followed by a case of adrenal insufficiency. So there is a strong recommendation for post-operative glucocorticoid replacement. And this won't be avoided as the preoperative medications with alpha blockade in pheochromocytoma patients. For the last few minutes of my presentation, I would like to concentrate on some specific issues. First, a special but not uncommon situation are patients presenting with bilateral adrenal incidentalomas, representing 9 to 17% of all these patients. Interestingly, patients with bilateral adrenal incidentalomas, as we have shown back in 2011, demonstrate a higher rate of autonomous cortisol secretion. And this has now been confirmed in future studies, as shown in this meta-analysis. The challenging question is, what is the best surgical approach for these patients? And there are several suggestions. To operate on the basis of no cholesterol uptake scans, like our French colleagues do, to perform catheter studies in order to depict the dominant side, or undergo the most simplistic approach, which is to remove the largest lesion. And as shown in this study we did a few years ago, such an approach improves hormonal abnormalities and, most importantly, improves comorbidities compared to the conservative management. Occasionally, some other forms of adrenal lesions are depicted as bilateral adrenal incidentalomas, like macronodular adrenal hyperplasia or primary pigmented nodular adrenal dysplasia. Many patients with macronodular adrenal hyperplasia have aberrant tumor receptors for hormones such as gastric inhibitory peptide or for beta adrenoceptors. While of great theoretical interest, they are rarely of long-term treatment utility. A substantial proportion of patients with this radiology phenotype of macronodular hyperplasia harbor mutations for the AMPC5 gene. This is an example of such a case And this is probably the first case depicted in Greece as part of a study we performed with our Oxford colleagues a few years ago. And what is most interesting is that following this index case, we went to the family members with his unaware daughter presenting with substantial adrenal enlargement and definite biochemical abnormalities of cortisol excess. And the question is, what is the optimal management of individuals with AMC5 mutations without any clinical stigmata of Cushing's? Another interesting issue is the demonstration by Wipke Alt's group by the method of steroid metabolome analysis of mild cortisol excess in patients with classical primary hyperaldosteronism. And they nicely described this condition by combining Con and Cushing as Consing. This has now been further confirmed in recent studies, showing a prevalence of mild autonomous cortisol excess in 4% among all cases of primary hyperaldo and 27% in cases of aldosterone-producing adenomas. Interestingly, some implications, like impaired glucose metabolism in such cases of primary hyperaldosteronism, are due to the concomitant cortisol co-secretion, and therefore it is concluded that mild cortisol excess is frequently found in primary hyperaldosteronism and contributes to the associated metabolic risk. So mineralocorticoid receptor antagonist therapy alone may not be sufficient to counteract adverse metabolic risk in medically treated patients with primary hyperaldosteronism. A final point, we currently think that adrenocortical adenomas are steroid-producing tumors that predominantly secrete a steroid product that characterizes the tumor as aldosterone, cortisol, or whatever else is producing. However, the situation is not as simple, since in adrenocortical adenomas, steroidogenesis may lead to excess release not only of final steroid products, but also of many precursors as well, that may have a significant impact on the clinical phenotype. And this is illustrated in this example, showing concomitant secretion of multiple steroids, including steroids of both the glucocorticoid and the mineralocorticoid pathway. And these profiles are now depicted by mass spectrometry. And thus, in the era of steroidomics, the steroid profile may characterize the clinical phenotype. And this is nicely illustrated in this study, where the steroid expression of corticosterone, a mineralocorticoid, depicted by steroidolomic analysis, along with mild autonomous cortisol excess, resulted in a more aggressive in terms of resistant hypertension phenotype. So, to conclude, subclinical Cushing, nowadays called mild autonomous cortisol secretion, is a common disorder affecting approximately 10% of patients with adrenal incidentalomas. Autonomous cortical secretion is a predisposing factor leading to comorbidities like hypertension, diabetes, osteoporosis, and also leads to increased mortality. Bilateral adrenal incidentalomas is a special challenging situation of autonomous cortisol secretion. Surgery is indicated in carefully selected patients, and medical options targeting night cortisol excess may be a promising future option. And finally, steroidolomics allow the diagnosis of mixed types of steroid excess that lead to different clinical phenotypes. And this new field represents a major challenge for future research. And with this, I would like to thank you very much for listening.
Thank you very much, Dr. Zagarakis. If Dr. Krigezopoulou would like to comment.
And congratulations, Stelios. It was an excellent presentation. I don't have any comment because Stelios Tsakarakis is the leader in diagnosis and the treatment of subclinical and clinical Cushing syndrome. And I don't have to say anything.
Okay, Professor Waltz, would you like to close the session?
Oh, no, that's too much of an honor to close the session now. But of course, congratulations to this interesting data about the mixed secretion of hyperaldo and Cushing. So hypercortisolism and hyperaldo. I have a very simple question. I have done more than 500 operations on Conn's syndrome, and most of them had Conn adenomas. Of course, some hyperplesias are always there, but I have never seen a Addisonian crisis after that. So what does it clinically mean if you have a cortisol secretion in these patients?
That's a very good point, because you'd expect if there is mild autonomous cortisol secretion to have some cortisol decrease after removal of the adenoma. In fact, there are some observations indicating that if you look at these patients postoperatively, because we never actually look in operated patients with primary aldosteronism for what the cortisol situation is. And because the possibility to get into a crisis is not the usual outcome. I mean, you end up with some low cortisol, feeling unwell, etc., etc. We now look at this, and I'm aware that also other endocrinologists looked at that, and I think that Martin Reinke in Munich also looked at that, and they found some cortisol decrease following operations in such cases. But I accept that your experience, but if it was something more evident, you should have seen that. For example, we were not looking for hypoaldosteronism for many years before, but we now see many patients with hypoaldosteronism after aldosterone surgeries. And I'm sure you realize that in your patients as well.
Thank you.
Thank you very much. Dr. Lanitis, please summarize the meeting as president of the meeting. Thank you very much.
I will probably do that in English, so to honor our guest here. First of all, I'd like to thank Professor Waltz for being here with us. It was a great honor having him. I would also like to thank all the speakers, all the commentators, and everybody who contributed to this meeting. It has been a long journey, actually. It has been 3 months organizing this and trying to get in touch with everybody, because it was a high stake having all this voting and having everybody cooperating to get this. And I'm very glad that everybody contributed equally to this, to the success of this meeting. I would also like to thank the PRC Travel for organizing this, Mr. Andreadis for the IT support, and of course our sponsors for being always there for us, giving us the chance to do all these meetings. Most of all, I would like to thank all these participants for leaving their journeys and whatever their vacations to be here and attending this course from 9 o'clock until now. Thank you all for this, and I will leave you go and enjoy the rest of the weekend. Maybe Mr. Zographos wants to say something else, or?
Oh, I think we are running late, so the discussion for this very interesting lecture was limited. Perhaps I know that there are many people who would like to comment now, but unfortunately we are running out of time now.
So thank you very much, everybody, and hopefully the next time we'll be all meeting together in person.
Thank you very much. Congratulations. Congratulations.
Thank you very much.
Have a nice afternoon.
Thank you.
See you. Bye.